Hi, it's Dr. Philly, and we're going to take a look at a case where the sonographer was questioning a small stomach. Um, Interestingly, on this first scan, we can see the cervix, and there's all kinds of stuff covering the cervix. This could be a lower uterine segment contraction, could be a big previa. We'll have to take a look at that as we go through. Okay, so identifying that the tip is here, so this is probably going to be a lower uterine segment contraction. Again, though, you want to look at this as the bladder, maybe if the bladder emptied later on in the scan, the lower uterine segment contraction can go away. So as always, you want to do general survey of the fetus. You get the lie, get a look at the fluid, and actually the fluid is looking kind of generous here, and considering the fact that the question was small stomach, that's going to be important. And deepest vertical pocket is 7.4 well, okay, she was thinking the same thing as me. So about 7.4 centimeters, posterior placenta. So we're going to want to do a formal AFI, and right on cue, AFI is 19.7, so that's generous. I use 25 for poly, but anytime you're getting over 20, the fluid's certainly getting up there. It's the AFI is, while it's what I always say is, while it's an objective measurement, it's a very subjective way that you get it. So, baby's saying hang loose here. Anyway, so the measurements are looking okay as far as quality. She's getting good pictures. That's probably the stomach. But as we went through the abdomen here, really not seeing much of a stomach. We'll check out some cine clips. Urinary bladder looks okay. Extremities are looking good. I always like to look at the feet in coronal section like this. You're making sure nothing's popping out the side like a club foot. All the extremities look good. So you always want to look at this, at least I always look for the stomach on the abdominal circumference images because it should be in the picture, and it's really not. So there is a small stomach. We have a sort of a nice three vessel view. You can see that we're way up high. The ribs are, you're seeing three ribs over here. This is probably the first rib, so she's really kind of angling down in this thing. So that's why it looks a little funny, but you do see three vessels. This is better. Certainly passable as a normal three vessel view. Nice four chamber view. So clearly we've got a small stomach. This is a good example of excess fluid just from a gestalt standpoint. Normally the abdomen, the head, the chest should pretty much fill the cavity, and then you should see fluid sort of interspersed around the small parts. And there's clearly a lot here. So everything else I was just about to say, we never got back to the cervix, but right on cue again. Here's the cervix. Placenta's clearly way back here, so there's no previa. So basically we're left with a small stomach and pretty generous fluid. So what can cause that? If you have dilated bowel and excess fluid, obviously you're thinking about a bowel obstruction of some sort. But if the stomach's small, then the obstruction has to be somewhere up in the chest. And if you want to be fancy, we could look for a dilated esophagus in the chest. So let's see if we can pull up, this should be a cine clip of the chest. So we'll scroll through here. Let me slow it down a little bit and just kind of scroll through like this. So here's the heart, the aorta. This echogenic structure is actually probably is the esophagus, but there's no fluid-filled esophagus. So what we're thinking about is possible esophageal atresia. It can be pretty hard to diagnose that specific entity on ultrasound without, because you'd have to really see a dilated esophagus up in the chest. So you can certainly question it and follow it up later. Say, we see a lot of fluid or a generous amount of fluid. There's and there's a small stomach. The stomach is often just small. It can fill and empty, and a lot of times if you just bring the patient back an hour later or even by the end of a study, it'll come back. Certainly if you bring them back in a couple days, then the patient doesn't have to wait around worrying about whether or not there could be an esophageal atresia or some other horrendous anomaly going on. So, I would definitely raise the concern in this case, but I wouldn't, I would somewhat reassure the patient saying, it's probably going to be okay. Let's just follow it up and see what happens. But certainly something to watch. Um, and the biometry here all looks good. So hopefully that was helpful.